the theme of linking research to policy and the practice. Just to give you some background information on what the SN-Net International and its hubs are. SN-Net International is a global knowledge platform on sexual reproductive health and rights that is organized in hubs in some countries, each of which constitute one or more communities of practice. The communities of practice engage in knowledge management and linking practitioners, researchers, and policymakers. They generate, translate, and share knowledge via the extensive networks of local, regional, and international level actors. SN-Net International intends to influence policies and practices and advocate for greater impact of programs targeting sexual and reproductive health and rights issues. So SN-Net International combines the expertise and the strengthens organizations and the key international actors working in the area of sexual and reproductive health rights to achieve the sexual and reproductive health rights and the gender-related sustainable development goals. In addition, the platform encompasses the national knowledge networks in 7 countries that include Ethiopia. The other countries being Bangladesh, Burundi, Jordan, the Netherlands, Burkina Faso, and Colombia. These networks serve as conduits for situation assessment, defining research priorities, facilitating research participation by country institutions, and hosting the local knowledge base and platform. They also stimulate the participation of key international partners and regional and national actors in sexual and reproductive health rights based in their countries. SN-Net Ethiopia is one of the country hubs of SN-Net International, hosted by the Consortium of Reproductive Health Core to serve as the knowledge platform for sexual and reproductive health rights in the country. So with this background, what has been done, when this announcement came, SN-Net International announced young researchers to submit their abstracts, that is, which they under, graduation, or those who have done their masters, or those who have done their thesis in another areas, even if they didn't finish to, submit their abstracts, so that the abstracts could be, evaluated based on the criteria that is set. Accordingly, this announcement came this year with, a deadline of abstract submission in August 2021, and later on those abstracts that have been okay. I just did that because of just to sorry. Can you see me now? So
Yes.
yeah, so this call for abstract was made, as I said, for those young researchers below the age of 35 years to share their research works to the international community and also to the fellow countrymen what that they have done. Once the abstract have been submitted, the abstract were elected based on the content, based on the set criteria, particularly on the based on the justification, the theoretical framework, the methodology, the innovation, and particularly the relevance for the research policy and the practices. In fact, for those people, young researchers who were interested to participate in this platform, an online capacity building, abstract writing capacity building have been given by two professors, myself and Professor Bill Dahas from Groningen University. And based on that, those young researchers have modified, adjusted, and also beautified whatever research they have presented. Accordingly, they have submitted their final abstract. Those abstracts have been evaluated by experts at the different hubs. For example, in the Ethiopian setting, 3 experts, myself, Dr. Terefe, Degefa, and Mr. Dejeni from Kora have evaluated. Based on this criteria, we said this criteria I just mentioned, the justification, the theoretical framework, the methodology, the innovation, and the extraneous. Based on this, we have accordingly couple of abstracts that were submitted from Ethiopia have been evaluated, and 3 abstracts were selected. The 3 abstracts that have been selected are: one is provider perceived benefit and the constraints of complete adherence to antenatal care guideline of public health facilities in Ethiopia. This is a qualitative study by Tewodros Seyoum. The second abstract was knowledge level and the factors on sexual and reproductive health right among University of Gondar. This is by Keflie, Yohannes. And the third one is human papillomavirus in women with invasive cervical lesion and cancer. The use of urine as an object specimen by Ededia Firdawoke. These are the 3 abstracts that have been selected for today's presentation. But before inviting these presenters, let me just give you some bios of our today's presenters. I will start from Tewodros. Tewodros Seyoum is a 35 years old clinical midwifery specialist. Tewodros has been closely working with the Ethiopian Midwifery Association and the Ministry of Health. He has ample experience in teaching and learning, research, and community services in the last 9 years since he has been engaged in this activity. This is a short bio from my side. In fact, if there are something that I missed, Tewodros will present himself more when he is presenting his presentation. The second presenter is Yohannes Gabraselase. He is a 31 years old registered midwife who has an PhD in reproductive health and child health. He is currently serving as a team leader of Sexual and Reproductive Health Service Unit at the University of Gondar Comprehensive Specialized Hospital. He had more than 7 years experience in providing sexual and reproductive health service in the clinical setting. The third presenter is Ededia Firdawoke. Ededia is currently in Norway, I guess. She has already posted her presentation using video, but in case she is able to join us, we will just see that later. She is a graduate in BSc from Ababa University in Medical Laboratory Technology in 2014. I could guess that her age is below 30 or so. She received her master's degree in medical microbiology from the Seme University, Addis Ababa University, and also she is a staff at Addis Ababa University. So these are our presenters. Our discussant, as you know, is Dr. Meseret Zelalem, who is a good colleague and the boss of us. She's a medical doctor and a pediatrician by profession. Currently, she's working as the director of RMNCH Directorate at the Federal Ministry of Health. Prior to her current post, Dr. Meseret has served in different capacities at different places. One of her post was that she served as the chief of staff at the Minister Office in the Federal Ministry of Health. Prior to that, she worked as an assistant professor of pediatrics and child health and a clinical director of the University of Gondar Comprehensive Specialized Hospital. So with this brief introduction of today's conference and all the participants, the presenters and the discussant, let me invite the presenters. to present their work accordingly. The first presenter is Tewodros Seyoum. Just as a note, you have 15 minutes to present for each of you, a total of 45 minutes for presentation, and the rest of the time will be used for discussion, for questions, comments, and so on. Is it clear?
It's clear.
Yeah, so Tewodros, the time is yours now.
Okay.
Seme, are you controlling the timing?
Okay. I will do that. Dr. Assefa, if you stop sharing your screen.
I didn't share any.
You didn't share? Okay. Tewodros, can you share now?
No, so I can't be able to share my slides. So I think there is something wrong. I think it would have been better to.
I would do it from here.
And, I will present to the public.
Okay. Thank you.
So sorry, I just see one of the comments in the message that he was not hearing. Is my voice not heard?
What?
Was there any difficulty in hearing me?
አይሰማም ነበር እንዴ ድምጼ?
ይሰማል።
አንድ ሜሴጅ አግኝቼ ነው አይሰማም።
All right. So
right. Now you can start.
Thank you very much, Tewodros Seyoum, and I'm a midwife, and I'll have a presentation with entitled Reproductive Persist Benefits and Constraints of Complete Adherence to Antenatal Guideline among public health facilities, which is a qualitative study, and this study is published in +1. Please go. Would you please go ahead, Seme?
Yeah.
All right, and I'll have some sort of presentation outline with introduction and to having some recommendation. Next. So to start with the introduction, what's known about the problem, and it's known that Antenatal guideline is Antenatal is supported with a guideline with formerly adapted from WHO with 4 visits with at 4 independent time, and later on it is changed into 8 contact and guideline by 2016, and Antenatal in the form of guideline has been emerged, and this movement brings generating evidence with the final objective to update the ANC guideline. Go on, please, Seme. So in spite of having those evidence at hand in many low and middle income countries, turning this evidence-based focused ANC guideline into clinical practice is a missing link, because the evidence is at hand with high-level evidence, but we failed to translate this evidence into the clinical setting. Next. So coming to the Ethiopian context, healthcare providers' level of adherence to the national ANC guideline is relatively low. And the reasons why healthcare providers are not following the ANC guideline is not well known. And it was crucial to understand that and learn from the healthcare partners from themselves about why they are not adhering to or why they are not following any guideline is our research gap. Next. So our objective is to explore the provider-perceived constraints associated with complete adherence to any guideline among public health facilities in Gondar town. Next. So to say something about the matter section and the studies conducted in 4 public health facilities in Gondar town, with having 1 hospital and 3 health centers. And the study design is a descriptive qualitative study, and our study population was, midwives and obstetricians were the part of the study and part of the interview. And to the study, 9 healthcare providers, including 2 obstetricians and 7 midwives, were purposely selecting and be part of the qualitative study. And we used an in-depth interview, and it was recorded with audio. And finally, our data was analyzed with inductive content analysis by using some advanced softwares. Next. So coming to the result and discussion section, and healthcare providers perceive that using and following any guideline has so many benefits, like improving the quality of care, and it guides and it improves the competency of healthcare providers. And in spite of having these benefits, they fail to follow the guideline due to the following reasons. And the factors have been categorized into 3 major categories. And the first category was organizational or system level factors, like guideline-related factors, human resource-related factors, lack of appropriate health setup, and logistic-related factors. And the second factor was care providers' knowledge and attitude and skill, and it was related with providers' existing knowledge, attitude, and practice. And finally, factors related with training and mentorship has been both the in-service and pre-service education was one of the contributing factors that affects providers not to follow any guidelines. Next, Seme. So to say something about the individual factors, the first factor was organizational or system-related factors, and among the organizational factors, the guideline itself, with this content, accessibility, and usability, was one of an overarching challenge, which is collected from during our interview. And in spite of those factors, they said that accessibility of any guideline during clinical practice on the internet by using mobile phones was the fascinating, one of the fascinating factors that helps them to refer things quickly. And a similar study has been reported in Ethiopia around in Jimma. And the other factor that affects providers not follow guidelines was scarcity of equipment and supplies as a health facility. And it was mainly affecting them at health centers. And scarcity of this equipment and supplies mainly frustrates both the provider and the clients to provide quality of care. And women were forced to turn their service to private health facilities, and they incur additional costs. And the other factor was human resource and patient-related factor among organizational factors. And there was provider to patient ratio was not proportional in some health facilities, particularly on health centers. And there, one midwife in a certain health center is supposed to have more than 20 up to 40 clients per day. So they may exempt some essential content of the guideline in the setting. And they said that to evaluate a single client, it takes more than 15-20 minutes. So to give the service for all clients, I might be in a rush by exempting some essential NSC packets. Next. And the second major factor was factors related with care providers' knowledge and attitude, as well as the skill. And some of health providers said that they do have, poor attitude to use, focus guidelines during antenatal care, and it's all mainly pronounced in like obstetricians and students like medical internists are not willing to use ANS guidelines, and rather they prefer to use international books to provide care for patients. And some of the clients also are not willing to use guidelines due to the lack of motivation and commitment to follow guidelines. And there are factors that smash their motivation, like lack of incentives and workload in health care setting. And it is supported by other studies done in Mozambique, Ghana, and Bangladesh. And the other thing is providers, variations in providers' knowledge and the skill on the ANS guideline, and mainly on graduating midwives and midwives. And medical internists are not usually, familiar with the content of ANS guideline, and they believe that if the women are coming too early before 12 weeks of gestation, they are not willing to provide some essential services like iron and folic acid, and they are not doing some, physical examination like abdominal examination if they are coming in the early gestational age. So, out of the care. Next. And the other factor was training and mentorship, both in the in-service and pre-service education, and usually in the teaching hospitals, senior obstetricians are not providing, care for. They provide more emphasis to the teaching of students, the clinical setting, so it affects the quality of the guideline. So as a conclusion, although providers acknowledge the benefits of following ANS guidelines, they were not fully translating the guideline into practice. Organizational related factors, care providers' existing knowledge, attitude, and skill, and a variety of training and mentorship were the three main reasons that hinder not to follow ANS guidelines. Next. So, based on our finding, we have some sort of recommendation for policymakers, programmers, and midwives as well. So, as a policymaker, the Federal Ministry of Health should also update and implement the newly 8 contact ANS guideline as per the WHO recommendation, because they said that the ANS guideline is outdated. It's not updated regularly. And for the message programmers, the ANS guideline should be modified with practical, simple, and easy to follow flow charts that users could refer just quickly. And the guideline is to be readily accessible online with user-friendly format, with like digitalization. And training on ANS guideline implementation should be given as a continuous professional development for midwives as well. And there has to be urgent revisions on the supply chain system for supplies and equipment for full implementation of the package facility. Next. Excuse me. For public health facilities, the ANS guideline should be posted on the bulletin board of all ANS rooms that providers make refer easily on the board, and balancing the number of clients that can be attended by each.
2 minutes, Tewodros, 2 minutes.
And motivate healthcare providers by offering periodic certificates, recognition, and incentives based on the level of performance. And for midwives, midwives must have an active role on the development, implementation, and update of ANS guideline. And for future research, we recommend that the level of healthcare providers to ANS guideline involving private health facilities and rural settings should be assessed because we're limited to the public health facility found in the urban areas. And future study has to be done on effectiveness of the aid contact and model in the Ethiopian context. Next, Seme. Thank you very much for listening us. Thank you. Over to you, the chair.
Okay, thank you very much, Tewodros, for the nice presentation. I think you have used your time wisely. I think you finished within the 15 minutes allotted time. As you have seen, this is one of the important topic, the important area that has been covered actually, using guidelines. Guidelines are meant to guide health workers to give the service that is needed based on the set protocol, the set rules and regulations. If somebody is not following the guideline, either they may not fully or correctly provide the service that is supposed to be provided by the health worker. There are 3 levels, reasons why people are not using guidelines, as Tewodros has put, the organizational and system level factor, the provider related factors such as knowledge, attitude, and skill, and also the lack of training and mentorship. And these are very important, I think, findings for which Tewodros has already put recommendation for different level of actors, including the policy level. In fact, Dr. Meseret is going to say something later on after the presentation. Okay. So I think we have to go into the second presentation, and the discussion will be done finally for all the 3 presenters. So let me invite the second presenter, Keflie, on knowledge level and the factors about sexual and reproductive health right among University of Gondar students. Keflie, the floor is yours. Seme still follow the time. Thank you very much.
Okay, then thank you, Dr. Assefa.
Just as a notice, please switch off your mute, unmute yourself when you are not talking the others, because the background noise is disturbing the presenter and the listener. Thank you.
Okay. Okay, thank you, Dr. Assefa and Dr. Meseret. And I also want to thank the ShareNet members and all the participants for having this opportunity. So our study was conducted on University of Gondar and it was about knowledge labeling factors on SR rights, some University of Gondar students. So these are the outlines. At the end, we have recommendations for respective stakeholders. Thank you. Next. So, as you all know, SRH rights are right for people to make choices on sexuality and infraction. That includes the right to define one's sexuality, choose one's partner, and receive confidential, respectful, and high quality of services. They fall within 12 basic human rights, and they are summarized as the right to life, liberty and security, and the right to privacy. Healthcare related rights includes access to information, education, and counseling, and SRH services like family planning, and the right to harmful traditional practices, and the right related to reproductive technologies, to use the reproductive technologies, and the third one, the right to be free from inequality, violence, that's both sexual and gender-based violence, and the right to be free from discrimination. And the fourth one is the right to have a freedom of opinion and expression. Also, these are the basic human rights that are basic for SRH rights. Next. So in a study conducted in South Ethiopia, 45.5% of students lack knowledge about Israeli varieties, and also 8% don't know about practical services. So lack of those knowledge helps to having those knowledges helps to halt neglected issues like adolescent sexuality, gender-based violence, abortion, diversity in sexual orientation, and gender identity, and other SRH-related problems. So despite those, as we all know, there were different researches conducted related with SRH and SRH services. So most of the studies show that there's a burden related with the problems, but related with that, studies lack and the study aims to bridge this information gap among stakeholder students. Latest. So regarding the method, initial discussion study was conducted from March to April at University of Gondar, and all regular students with the social state populations, and we use next stage random sampling to select students from the 10 faculties and respective departments. We use the structure and prescriptive self-administered questionnaire. For using those assumptions, total of 814 students will participate in the study, and info software we use for each data entry, and space for version 20 for analysis. And we by variable vector selection was used to assess the factors, and with the p-value is than 0.85 as a significance, and post-measurement and show test as a goodness of fit test. Next. So related with the variables, dependent variable is the knowledge, and on SRH writers, 24 questions were asked, and students to score out of the level we consider to have an optimal knowledge. Independent variables include socio-demographic and academic variables, and also SRH variables as displayed on the screen. Latest. So as a result of discussion, a total of 827 participants, students who participated with response rate 98.8%. As key findings from the study, the mean age of the participants was 21.3 years, with the standard deviation of ±7, and 51% of participants were males, and 50.4% were from health science faculty. Regarding their sexual experience in practical socialization, 20% have sexual experience, and their mean age at first sex was 8.5 years, with standard deviation of ±0.1 years, and 32.4% of the participants start their sexual intercourse after they join university, and 56% has more than one sexual partners in their lifetime. So this showed that most of the participants practice sexual intercourse after they join the university, and most of them, that means more than have multiple sexual partners. Next. So the overall swan knowledge on SRH rights was 57.10%, and the study conducted in Ethiopia and Pakistan. And the study is higher than study in Nigeria, and the possible reasons are difference in study population. That means in Nigeria, the studies were conducted on females and adolescents. As you know, our studies conducted on both male and females. And also it might be due to the high proportion of science students in our study. So these are the possibilities for having high level of optimal knowledge on arthritis. Related to the factors, there is a reduced knowledge among Muslim students than Orthodox Christians. It might be sensitive that our finding shows this, and the regions where majority were Orthodox Christians, that is 83.6%, and they were also most likely to discuss about these rights with friends, healthcare providers, and teachers. And the second factor was those who come from urban areas were more likely to have knowledge, and this is in line with the study conducted in Assefa University. And the reasons are people from are less likely to use media or newspapers, and their knowledge could be negatively affected of established writers. And the third factor, the third factor is the loads of knowledge among faculty information, faculty information and education, than in science, and this supported by this might be due to that health science students, in addition to their written readings, they might learn about arthritis in their reproductive and related courses. And the other factor was high knowledge among students. Clinic provides RH services. As you all know, student clinics provide RH services. Some of them are functional, some of them are not. So the possible reasons is when students visit student clinic, they might get information, education, and counseling services on arthritis, while they give for other services. And these are the factors. As a conclusion, large proportion of students don't have optimal knowledge about arthritis. As we see, 42.3% of the students lack the knowledge on arthritis, and the factors were religion, place students came from, faculty, and availability of RH services in students' clinic. Next. So as a recommendation to University of Gondar, it's better to provide all training and sexual education related courses for all students, and it's also better to make students clinic more comfortable for and keeping the privacy and confidentiality for use of these services for the students. And the second recommendation is for researchers. It's better to conduct qualitative researches on arthritis, and they push to explore and dig out potential barriers. And the third one is to Ministry of Education. It's also better to incorporate standardized and integrated sexual education programs into higher education institutions curriculums. And the fourth one is to Ministry of Health and the Regional Bureau. It's better to conduct awareness creation on sexuality education programs that are culturally and contextually accepted manner to parents, community, and other stakeholders, because unless it's culturally and contextually accepted, it will have, I think, it might not be accepted by the community and other stakeholders. So it's better to make it culturally and based on the setting that we have. And latest. So an acknowledgement, we acknowledge for all the study participants, data collectors, and supervisors who participate in this study. And I hope I finished my, so these are the sample references. And so thank you for your time. I think Dr. Assefa, you can continue.
Thank you. Thank you very much, Keflie. Again, this is also a nice presentation. You also managed your time, in fact, 1 or 2 minutes less than the allotted time. Yes, definitely. This is also one of the burning issue, one of the controversial, points, the issue of, sexual and reproductive health rights. So you have assessed, knowing one's sexual and reproductive health right will help use it, ask for it, and then make use of it. If somebody doesn't know, or probably he or she may not ask for it, you try to identify some of the factors that could affect the level of knowledge, including religion and also, the exposure, like, which you try to exemplify those people who are exposed to the RH service to better know about sexual rights than the others. So exposure matters a lot, definitely. So accordingly, you have recommended, you have indicated a recommendation for different level for the researchers, for the university, for the Ministry of Education, and for the Ministry of Health. I'm sure we will later on see by Dr. Meseret about these recommendations, how appropriate they are, how relevant they are, and how we can contextualize to our context and then use accordingly. Thank you. So having said this, Seme is Ededia online now? Is she going to present, or are we going
I don't
to
think she's around, doctor, but I think I can share the video. Maybe the sound is not that much clear, but let's have the video, I think.
Sure, sure. Let's go ahead with that, and then we go into our general discussion.
Hello everyone, I am Ededia from Ethiopia. So our project title is HPV in women with cervical lesion cancer in the specimen. So this is my outline, so I will give you an introduction.
I think we cannot yet see the video, I'm afraid.
Semena, we can't see the video.
Yeah, Seme.
Huh? Video?
We see you, not the video.
Yeah, the presentation and her video is down.
Oh, it's an audio presentation.
This is an audio, yeah?
Okay, no, then it's fine. Then it's fine. Maybe you can make it a little louder, but we could hear her.
It's not me.
The one you sent to me was a video, Semena.
Let me try.
Hello everyone, I am Ededia.
Wait, okay, quite an example. And now?
Perfect. Yeah.
So this is my outline, so I will give you an introduction. I will try to get the result. So as an introduction, because of the small and developed, so I guess more than 400 has identified so for the development of cervical cancer, certification is the highest required, and with the screening of the cervical cancer, in most countries it's based on cervical examination. And as a result of this, it's when the cervical cancer incidence and mortality, but the cervical screening is more subject to the because it has high in addition to that, it's very easy for the collection so recently the study there were 640,000 cases of cervical cancer. The cervical had high
BT.
Seme, if you mute yourself, we also have the audio muted, so then we cannot hear the presenter anymore.
Yeah. We cannot hear her. Semena.
Yeah, I don't know what to do about it, but
It is okay, Semena. Now it's okay. Just if you increase the volume, that would be nice.
it's 100% from my side.
Is it stopped? Semena.
Seme, please unmute yourself, then we can at least try and hear a bit of the presentation. Okay, perfect. Maybe stop the presentation while you do.
Hello. Do you hear? I can't hear anything. Hannah.
No, I think as long as Seme is muted, we cannot hear, but I really think that they're trying to fix it. So let's give them 1 or 2 minutes to see if we can
All right.
listen to the presentation, and worst case, we have to share it afterwards with participants. I think always a plan B.
Yeah.
But maybe Seme, you can give us a heads up how you want to proceed.
If he can hear us, yeah.
I think Seme is telling us in the chat that we are having difficulties with listening to this presentation at the moment.
Yeah.
Yeah, do you want to
I
say
think
a few words about that?
let's put the presentation, and I think the good thing would be to stop the presentation and to continue with the rest of the program, I think. And we will send you the presentation because we just received it from Norway, and I don't know how to fix it. The sound is really bad.
I think that's okay.
Hello, can you hear
we'll
me?
be happy to see
Sure,
later.
sure.
Thank
Hello?
you.
Yeah. Semena,
Let's share
yeah,
the video. I think.
you can share the video with the audience, but just to highlight what the finding of this survey done by Ededia, that she tried to look if there is a substitute for cervical samples. If urine sample can help substitute cervical sample, because cervical sample taking is monotonous and it's somehow.
Dr. Assefa, I think
very...
Ededia is now joined us. I think.
Ah, really? That
I think
will
so.
be good. Then.
Ededia, can you hear me? Ededia. Ededia, can you hear me? She just joined. Ededia.
Yes.
Can you? Oh, thank you.
Welcome,
Can
welcome.
you?
Yeah, I heard you. I can hear you.
Okay. Can you briefly present your presentation? We have been trying to make use of the video, but unfortunately the sound it's not that audible, and there was some technical difficulties we had.
Okay. Can you give me a few minutes?
Sure.
So the video quality is poor?
Yeah.
The sound, and particularly the sound,
The
we cannot
sound.
hear what you are saying.
Okay. Forward language.
Can you present it now, Ededia, or what?
Just give me a few minutes. I don't have a PC, so that I should use my phone, okay? And yes,
Okay.
presentation.
ቪዲዮ እንትን ብትል ከዛ ላይ ማለት ትችላለች። ለነገሩ ደግሞ ድምፁ ይረብሻል ደግሞ።
Ededia, now you are a co-host. I think you can share your screen. Dr. Assefa, can we maybe there
Okay.
are some questions in the chat. Can we answer them for the first presenters in the meanwhile?
In the meantime, sure. But yeah. So, I mean, let's do this. Lydia can, step in. I mean, Lydia can step anytime she's ready. Until then, let me hand over this to Dr. Meseret to, start in the discussion. In the discussion, we can also, point those questions that have been already in the chat box. Dr. Meseret. Is Dr. Meseret there?
Thank you very much, Dr. Assefa. Do you hear me?
Sure. Yeah, please go ahead.
Thank you very much indeed. Thank you, colleagues, for the great presentation. So now this is a real time to start them and raise questions, feedback, and any concern. Either you can raise your hands or put in the chat box.
Yeah, there are some questions already in the chat box, Dr. Meseret.
I will see that one. Till then, I see Hannah Mersha has raised her hand. I will give the chance to Hannah. Hannah, would you please proceed?
Thank you so much. Hello, everyone. Good morning.
Good
I
morning.
guess I need to introduce myself first. My name is Hannah Mersha. I work for Gender Health. I'm monitoring, evaluation, and learning advisor. It's very recently that I've joined Gender Health, and this is just my second week. It's my first time attending a ShareNet session, but I've been briefed about both ShareNet and Korha by our Chief Executive Officer, and also I've tried to look into the website. So it's nice to meet you all, and it's a privilege to be part of such a platform. And I'm looking forward to learn a lot from every one of you. Coming to the presentation, thank you so much for the nice presentation. The findings in all the in both presentations are very interesting. And my question goes to the first presenter, Mr. Tewodros. I guess he's here.
Yeah.
So,
Go ahead.
okay. So I want you to add a little bit more on the recommendation section. For me, the major aim of the antenatal care is to promote, protect, and maintain the health of mothers during pregnancy, right? So for that, as you've been presenting, the ANC guideline should be applied or adhered to. So it's not without a purpose that the government spends resources to bring such guideline into action. So my question is, what would you recommend for those who develop such kind of guidelines? It could be for policymakers or for people working at Ministry of Health, or those who are part of the MCH Directorate at the Ministry. What kind of innovative approach do you believe would contribute for the betterment of the applicability of such guidelines for the future? I mean, I heard you saying that policymakers should update the ANC guideline, but other than that, what kind of suggestions do you have? During your presentation, I've seen your recommendations, and most of it is geared towards either the healthcare providers or the organizations and the health facilities health professionals work at, and the quality of the trainings. But I want to hear your suggestion on what new approach would make these professionals more interested in applying or adhering to the guidelines properly. And I'm actually asking you this because this could be one of the potential area for us. And by us, I mean the civil society organizations and or the NGOs. We need to provide support for the Ministry of Health in particular, or the government in general. So can you please say a few words on this as you've conducted a very detailed qualitative study. Thank you.
Thank you very much, Anna. Is there anyone who would like to comment or raise a question? I see none right now. There is some questions in the chat box. I see the first one is from Galila Abram. It says, do you, for Tewodros specifically, the first question is, what are the underlying reasons for the observed constraint, like why providers are not motivated? This is the first question for Tewodros. And the second is also, do you think the recommendations are really practical? I mean, we need to touch what should be done. Example, how can a health facility balance the number of clients? Generally, given the nature of the design, we need to deeply explain the reason. I think these are a very important two questions which has raised for Tewodros. I hope Tewodros has captured. If not, I think you can see over the chat box. The second question is goes to for Keflie. As they say, thank you very much. And there are two questions. The first one is, I think student reproductive knowledge varies region to region, but if there are solutions in your study to close this gap, this is the first question. And the second is how to increase the awareness of the health facilities in the community on the reproductive health in the emerging region. So basically, this is for the pastoralist or developing region. What are the how can we really increase the awareness at the community level? And the first question, I think hopefully you captured this one. These are the few of the questions which has raised in the chat box. I see there is no additional question.
One more question before Galila's question, Galila Abraham's question. There is one question by Marsha.
Okay, Marsha. I tried to copy and paste. Where is that? Okay, please.
As it says, as the design was a qualitative one, was there any different finding with regard to the provider perception?
Okay.
Not to stick to the guidelines and the protocols. Is there any motivational related issues by the respondents?
Very good.
This must be question to Tewodros.
Thank you, Dr. Assefa, for the compliment. I think this is the time for Tewodros and Keflie. I will give the chance for Tewodros first. Do you hear me, Tewodros?
Yeah, I'm here. Thank you very much, Dr. Meseret, and for audience for your interesting question. And so most of your questions are acceptable, and I'll try to focus on very pertinent questions. So to start with, I think the last question, what are the main reasons for providers for not following guidelines? So as per our research finding on interview of healthcare providers, there are three major barriers or constraints that affect providers not follow guidelines. So the first factor was organizational or system-related factors. And among those factors, the guideline itself with its content, timeliness, and its format was one of an overarching challenge for the care providers, and including its accessibility. Even if the guideline is there at the national level, it is not accessible for healthcare providers as healthcare setting. So even if they want to it and follow it and for refer it when they need it, it's not accessible to health facilities. So they said that it would have been nice to avail these guidelines in the digitally based on internet like mobiles. So then when they need it, they may refer it quickly and implement what they need based on evidence-based practice or antenatal care. And the other challenge was, major challenge was, logistic-related issues like equipment and supplies, which is important for delivering all activities for healthcare providers. And it was really a major problem for all healthcare setting. And the other interesting challenge was, the number of healthcare clients with healthcare providers is not proportional. mainly in health facilities, in the health centers. So they are expected to cover all MCH services within a single midwife or two midwives. So to address all those clients per day, they may exempt some important content of antenatal guideline. So it affects really for full implementation of the guideline. And the other thing was question: what innovative approach do you recommend to any guideline? Like, first and foremost, it has to be updated regularly, and it has to be supported with digitalization. Like everybody should refer and use it when they need it on the internet. So that would be the best option as part of innovation on antenatal care service by using guidelines. And at last, I think if I'm following properly, I'm addressing most of your questions. And for the time being, I think it's enough for me. Over to you, Dr. Meseret.
Thank you very much, Tewodros. Thank you so much. Keflie?
Okay, thank you, Dr. Meseret. I just need two questions. So I'm not sure what was about on the first question, but on the second question, how to increase awareness on SN-Ethiopia issues among emerging regions. This is just, my recommendation is focused on two things. The first one is to just provide comprehensive sexuality education in all at education, in education. It should be standardized and it should be, as it should be implemented at each higher education institution. So the student is, at the universities, there is just a course, life saving skills. That's not enough by itself to increase the knowledge of the students on SN arthritis. But for emerging regions and for other stakeholders like communities, it's better to advocate on the issue because they might understand the issue when we present, when we show the problems related with SN rights violations. That is about early marriage, about abortion, about other issues. So with that two big approaches, we can increase the knowledge, we can advocate, and we can increase awareness among the regions, among other stakeholders. And I think Dr. Meseret can also add what's done on the menstrual field to on conference sexuality educations. If there's any updates, I think you can respond to that also. I think these are my questions, and thank you.
Thank you very much.
Dr. Meseret.
Dr. Assefa.
So this timing is fixed. It is going to close by 12:20. We are now left with only 10 minutes. So since Ededia is already back, can we give it just 5 minutes to highlight and then leave the other five minutes for you to summarize?
Please. Thank you so much. Thank you, Tewodros and Keflie.
All right.
Ededia, please take the stage.
Can you continue, please?
Yes.
Do it in 5 minutes.
Please.
Okay.
Thank you. Thank you.
Where is she? Where is she?
Semena ጠፋች እንደገና
በቃ
I saw her earlier, but she's no more there now.
I'm here. I'm just listening. I'm trying to share the PowerPoint, but it said it's unsupported file.
Can you do it without sharing then? We can listen to you.
Okay, okay, we'll do that.
Just do it in 4 minutes then. Now.
Okay, so the title of my project was Human Papillomavirus in Women with Invasive Cervical Lesion in Cancer in the use of the urine as ungemmed specimen. So as we all know, like human papillomavirus is a group of small non-enveloped double-stranded DNA viruses, and they are tumorigenic viruses that belong to the papillomaviridae family, and it has been like more than 200 type of HPV type have been identified and classified into 5 major genera. And this persistent infection with high-risk HPV infection is required for the development of the cervical cancer. So screening of cervical cancer was majorly, it was based on the cytological examination of the exfoliated cervical cells in most countries. And because of that, it declined the incidence and mortality of the cervical cancer. But this cytology-based screening is more subjective and relatively insensitive. So we need to have like some other tests like HPV DNA test. So HPV DNA test is more reliable and efficient as compared to other tests like cytology. So what we are trying to do is that we use the urine sample for the screening of HPV DNA test. So it is urine has like it could be alternative screening test, and it has also yield a high throughput and reproducible result as of the cervical sample. And it's very easy for the collection, and it's non-invasive strategy. So the significance of this study was, as we all know, in the year 2020, there were more than 6,400 new cases of cervical cancer, and there was like more than 342,000 mortality. So and Ethiopia being in sub-Saharan Africa, in the sub-Saharan Africa region, so the cervical cancer is the second leading cause of female cancer here in our country, and it can cause like more than 7,000 new cases and nearly like 5,000 deaths in the year 2018. So
go to your finding. Go to your finding.
Okay. So what we are, okay. So the main objective of this study was to determine the human papillomavirus genotype in women with pre-cancerous invasive cervical lesion and compare the concordance in tests to detect human papillomavirus from the two biospecimens, specifically from the cervical swab and from the first void urine. So the study area was at Tukur Specialized Hospital. It is hospital-based cross-sectional study. And our source population were all women aged 18 years old and above who are cervical compliant. Sorry. So the major finding of our study is from a total of 105 women, the 2 study participants were excluded. And from that, from our study, the age range of our participants were from 26 to 18. And the majority of our participants were aged 15 and above. And when we come to the prevalence of human papillomavirus, so when we see the overall prevalence of human papillomavirus among the biospecimens, so from the urine sample, we do have like 77% of activity rate of human papillomavirus infection.
Ededia, your main finding, what was your main finding? You don't have to describe others because of the timing we had. And then
yeah, I'm trying. I'm just only on the. So shall I go to the recommendation?
Yeah. Did you find that urine sample is the same as cervical swab? And then recommendation, tell us.
Assefa, excuse me, Assefa, kindly let her go because you are breaking down. She loses the flow. So just allow her the time to be able to go and then contribute, please.
But
just
it is
know
going...
that we are time scrap, because if you keep interrupting her, then the flow is lost.
I know, but it is going to close by 12:20, and we are going to lose the final conclusion unless she shorten it.
Yeah, I'm just trying to to see the prevalence of human papillomavirus in urine. So I just found that 77% of, we got that the prevalence of human papillomavirus in urine as 77%, whereas in the cervical swab, it was 83.5%. And when we compare the concordance between the diagnostic performance of urine HPV DNA test as compared to the cervical swab, so we have found that the agreement rate was 86.4%. And when we see the ROC analysis, so the ROC analysis or the area under the curve suggests that we just found that 0.82%. So this means that the urine sample could be as representative or could be used as alternative sample just to screen the cervical swab. So just when we came to as a conclusion, and the other result that could be described here could be also that HPV 16 is the most prevalent type that we able to isolate from the both cervical swab and the urine swab, which is followed by HPV 18 and others. Others type, and from this, from the low risk HPV type, HPV 53 is the most prevalent one from the low risk human papillomavirus type. So when we come to our as conclusion, so the overall prevalence of human papillomavirus across paired sample of the cervical swab and urine sample was 83.5% from the cervical swab, whereas it was 77% from the urine sample. And our study revealed a good diagnostic performance of urine sample for the detection of the cervical HPV infection. So we do. So we found that the overall agreement more than 85%, and the urine sensitivity and specificity was 88.4% and 76.5%, and the area under the curve was 0.8.
Thank you very much, Ededia, for the nice work. I think it suffices. Now we have left only with 2 minutes because the time is going to close before we close it. So Dr. Meseret, can you just give your conclusive remark?
Thank you very much, Dr. Assefa. Thank you, colleagues, for the great presentation, and apologize for Ededia that we really, made a huge pressure on her. Thank you very much, and thank you for understanding. Concerning all the presentation, I think the Ministry of Health, we have already done with the policies and strategies. We don't have any problem with the strategy and policy. We have revised the NC guideline, so it will be in place. I don't think that will be a problem. Concerning the SRH related issue in the university students and in agrarian area, we are really working on a tailored way of application in a way that we are working on a mobile application for SRH information, and also we are working closely to have equitable and accessible and quality SRH service at all level base. So I can say this is a great area of attention is provided at the Ministry of Health. It's our part of policy and strategy. We have a rich strategy. We have also NC guideline. We have also adolescent use health strategy, which overarching both all the SRH component and other non-SRH packages in the strategy. So we look forward to implement this one because in line with the SDG, we have several assignments to perform on SRH, and that is our big priority, I can say. So concerning the university students, I can say we'll also maximize our approach to reach out this needy community. And I really agree with the mobile application digital world to provide them a very important information. That's also in our action as well. In general, we are also working with other sectors like Ministry of Education. So Ministry of Education is working on a curriculum revision, and we are also part of that. we are providing feedback to include most of the relevant component of SRH for them. So we look forward to see what will be the final. The final draft will be discussed with the sectors, and hopefully we will contribute a lot. That is the highest agenda for Her Excellency Minister Leah. She is keep going with a great contact with the Minister of Education to realize this SRH is a part of the curriculum, because this is a big agenda plus a big opportunity. Unless we do it by this time, we're gonna to wait for 1 decade, which is 10 years, which will be a lost again. So that is in our attention, I would like to say. Finally, thank you very much indeed for a great chance. Thank you all presenters and your mentees. I'm really honored to be on a CARNET annual conference on linkage research policy and practice. Thank you very much indeed. We look forward to work with you all. And I recommend for the presenters to come to MCH, and you can discuss with my team, maternal health team, adolescent youth health team, and family planning team together. We have a Google session. So in that you can present your finding, and we can really look for a final policy brief based on the final recommendation after the team discussion. Thank you once again, Dr. Assefa and all colleagues. It's really an honor. I would like to repeat, this is an honor for me to be here happening on this virtual platform. I see these young researchers. This is a great linkage for the sector, for Ministry of Health, with the university, with the researchers, young researchers on this field area. Thank you once again. Over to you.
Thank you.
Thank you very much, Dr. Meseret.
My pleasure. Thank you, Abe. Thank you.
Okay, thank you, Dr. Meseret.
Yeah, I think apologies for Ededia for just hurrying you up, because we don't have time. That's why we did this.
It's okay.
And we also appreciate Dr. Meseret for really, appreciating whatever work you have done, and by her acknowledging that you go to the ministry, work with them, put into practice whatever the research outcome from all your research groups. And back to you, Seme and Abe, for the final say. From my side, that's all.
Yeah, actually, thank you very much. For sake of time, I have already put messages on the chat box, and I really miss Ededia to acknowledge, and I also ask apology for that. And thank you very much. We'll keep in touch with you. This is our first experience, and we'll continue working with academia, teaching hospitals, researchers, so that we can really contribute to the necessary action required to, Hello? No? Can you hear me? Okay, thank you very much, everyone. Thank you very much. We'll keep in touch. Okay. Goodbye, everyone. Good day.
Thank you. Goodbye.
Thank you so much, everyone.
All right, Hannah.
Yeah. Okay. Bye. Have a good day.
Bye. Bye.
Bye. Thank you.